if a patient comes in with Parkinsonism and lots of orthostatic hypotension with sexual dysfunction and they're very early in their course without any tremor, you want to think of another diagnosis like multiple system atrophy, where it affects or Shy-Drager is the old name for it. Increased salt in diet. Elastic stockings can be helpful. Have the patient sleep upright. Fludrocortisone can increase salt retention and help raise blood pressure that way, usually at 0.1 milligrams per day. Midodrine can also help as an alpha antagonist, I believe, and other drugs can also be helpful. Urinary problems can occur commonly in Parkinson's patients, so they can have symptoms of nocturia. A lot of folks have to go to the restroom at night as they get older. Hesitancy, urinary frequency, urgency, and incontinence. Actually, in one recent study, the Sydney Multicenter study, at 20 years of PD, 71% were incontinent. And you can occasionally use peripherally acting anticholinergics, but however, beware of these medications, especially in older folks. You may see this in your practice, just in general practice, for little old lady types, little old men that you give an anticholinergic to. They can get very confused on it. And again, you depend upon that acetylcholine a lot more as you get older compared to when you're younger. DDAVP can also be helpful as well for incontinence. We haven't used it very much though. Sexual dysfunction is very common in Parkinson's disease as the disease progresses, common in older men as well. Can be due to medications, so be aware of that. Can be due to depression and the usual features or psychogenic issues. Patients with Parkinson's have been shown to have testosterone deficiency, but a recent smaller study that was probably underpowered with testosterone supplements didn't appear to be that beneficial for sexual dysfunction in patients or overall symptoms that it appear. Sildenafil and the other, I guess they're phosphodiesterase type 5 inhibitors can be helpful. Apomorphine can be helpful and actually has a side effect of priapism. It's an injection that we rarely use in Parkinson's patients that can really help turn patients on, so to speak. And testosterone supplements may be helpful. I got a couple of slides left before I finish up, but I want to leave you with this study here that I mentioned briefly a second ago. There was a study that was done in Sydney, Australia at multiple centers, and it enrolled about 149 patients or so and followed folks over a long period of time. They're now at beyond 20 years for patients. And they reported in two different papers results at 15 years and results at 20 years. And the results are pretty sobering. And this reflects practice. In your early patients, they may be concerned about a lot of the motor symptoms unless they have depression, then that's certainly a very important one you deal with very commonly. But non-motor symptoms become paramount, and those that are frequently not responsive to levodopa are very troublesome as the disease progresses. At 15 years in their study, about a third of the patients were alive, so they had a standardized mortality ratio of 1.86, that is 1.86 times the standard population. A lot of the patients that were alive, the one-third left, had cognitive decline, a lot of falls, depression, choking, so pretty sad long-term picture for Parkinson's still. But at 20 years after diagnosis, 3/4 of patients were actually deceased, and for the 15 to 20-year range, the standardized mortality ratio was up to 3. Why is that an interesting number? Back in the days when Hone and Yar first studied Parkinson's, even before levodopa was around, the standardized mortality ratio was around 3. So even before levodopa. Is levodopa making a huge difference in mortality in Parkinson's? We're not so sure. Maybe it certainly improves symptoms, but patients still die at rates in excess of their peers. And a sobering 83% of the survivors that were still alive were demented at 20 years. I commonly quote to patients, if they make me give them a number, how long am I going to live with this disease? I say, well, usually 15 to 20 years, but many patients die of other things. They die of cancer, heart attack, stroke, the usuals. So it's not that they're dying of Parkinson's always, but if they have Parkinson's long enough, they can develop dysphagia to start and have aspiration pneumonia and falls and break a hip, those kind of things, and the dwindles in the hospital or the nursing home. That's what usually takes folks out with advanced Parkinson's if they die of Parkinson's disease. Well, what's the future of Parkinson's disease? Probably trying to detect it earlier by smell testing, screening maybe folks for constipation, even though that's very common. Maybe if you have constipation and loss of sense of smell, you're at much higher risk of Parkinson's. That may be a neat study to do in the future. The problem is that we still don't have a drug to slow Parkinson's down. We're working on that very hard. We're doing some NIH-funded studies looking at creatine as a possible disease-slowing drug. That's the muscle-building powder stuff that's in GNC centers that all the muscle builders use, the bodybuilders use. We're also looking at coenzyme Q10 as a possible disease-slowing agent and some other drugs. So hopefully in the future I'll bring good news that we actually have found a drug that slows Parkinson's down. The good news currently is that we actually have good treatments for the motor symptoms of Parkinson's disease. We don't treat the non-motor symptoms as well, but we're learning about that as well, and that's an area of intense research. I want to thank you for your time today, and I hope you enjoyed the talk, and I'd like to please take time to fill out the survey and the web link there. And for more information, contact on Health Tech DL events, please visit the website. And I don't know if I have time for any questions verbally or not.
I don't think so.
No, okay, don't think so, but I thank you for your attention and time. Take care.
Thank you. That ends our seminar. Thank you, Dr. Morgan, for your time and willingness to share your information. Thanks to all of you who participated. We're glad that you could join us, and we hope the session was helpful for you. Don't forget to fill out the online evaluation to receive your CME credit. We'll also send an email with a link to the survey. Thank you again, and enjoy the rest of your day.